Okay, I guess I'll start. Assalamu alaikum. I'm just trying to remember where we stopped. If anybody can remember, it seems to be here when we were talking about when someone is sort of informed that they have a terminal illness. Just wanted to tell you guys, today we kind of have a bit of a marathon. So we're going to be running to around noon. Have things I need to finish before your exam on Tuesday. All right, so unless anyone corrects me, I think this is where we stopped. So Kubler and Ross talked about 5 stages of how someone deals with, being told that they are going to die. Now, we deal with patients like this all the time because we have a cancer center at Cape Town Medical City. Somebody had asked me last week about DNR, and I just remember now, so I will respond to your email. Somebody wanted to know about what is the policy for do not resuscitate when patients are transferred from oncology to palliative care. So first stage is usually shock and denial, like being in disbelief. Then people go on to being angry about like, why me? And why am I suffering with this, and why is it going to be the end of my life? Then they get into a bargaining phase where it's more about like, if I have more time, I'm going to do this, I'm going to do that. Then they get into this depression phase where it kind of sinks in, and they start to have like sadness. Then they move on to acceptance. Now, where I work, there's also, and I believe in most hospitals and centers where they have oncology, there's usually people who are spiritual, like, so there's like a sheikh, or, depending on where the hospital is and what is the religious background, but there's usually somebody who's a spiritual person, and they're really involved in this process too, kind of trying to make people come to terms with it's God's will and whatnot. And for people who are religious, it just, the acceptance becomes a lot easier. Now, as you can imagine, it's extremely tough to go through this process. We usually get people referred in the 4th stage, wherein they're depressed, and so we get the referrals. Please come see this patient. Are they depressed or are they adjusting? And it's usually more of an adjustment. It's also really difficult to work with teenagers who are going through these stages because the anger is usually overwhelming. All right. Now, when you look at kids, again, how do they perceive death? I think I remember we went over this, but, it goes from death being asleep to being, obviously, when you're in your teenage years, understanding that it's an irreversible process. Like, you're not going to go and come back. You're going to go and never come back. Very difficult to treat young adolescents. And again, with older adults, looking back, at what they've achieved in their lives. So higher incidence or prevalence of depression as well in the older age group. Grief, mourning, and bereavement. We said that grief is a subjective feeling that's usually precipitated by the death of a loved one. The process by which grief is relieved is called mourning. And bereavement is the state of being deprived of someone due to death. So bereavement is a diagnosis in DSM. Okay, whereas grief and mourning, it's just like descriptive. Expression of grief, again, a wide range of emotions, and there's obviously cultural norms and expectations, and it also depends on the circumstances of the loss. So what is normal grief? Initially, when you hear the news of losing somebody that is close, and God forbid any of you go through this, initially it's a state of shock. This is usually short-lived. And then you have expressions of suffering, like crying, not sleeping, not eating, dreaming of the person who passed away. And we talk about survival guilt specifically when, people are in the same situation and then someone passes away and someone survives, and just feeling guilty about the survival. Denial is common, like not believing that this person has passed away. Illusions or hallucinations, again, happen and are normal. To think that you heard or that you saw the person who passed away. And then the identification phenomenon. I remember I told you about this girl that I was treating, where part of her problem was, she's wearing her dad's clothes, his watch, sitting in the same place, drinking from the same cup. So this does not really help people get over the loss of someone that they love. Bowlby talks about, again, stages of what it's like to lose someone. So it's 4 stages. Acute despair, denial, that usually lasts moments to days. Then there's an intense longing that usually lasts about months. Then there's a phase of being disorganized and being in despair, you're not sleeping with some weight loss. Then you have a phase of reorganization. And the person who's passed away is internalized. And what that means is that it's like pieces or parts of that person or memories of that person live with you forever. Okay, so you've internalized their kindness, you've internalized some of their habits, and so they will live with you forever. So that's really what it means. So how long does that take? Any ideas? Does anyone know? Hopefully not from a personal experience, but from readings or whatnot. How long does this usually take for someone after losing someone really close or loved to kind of get back on track? What is a normal time frame? Year, 6 months, 3 months, a long time. So they usually allow for around 6 months. Okay, so 6 months is given as a reasonable amount of time, after which people should really be getting back on track. And so those that do not get back on track, okay, it says 6 months to a year, but usually around 6 months. Obviously, depending on the conditions of the death, and sometimes you hear these horrifically scary stories where somebody loses 2 or 3 of their children in a fire or something. That's a really horrific death. Do you ever get over it? Losing a child is sort of the number one most distressing type of loss. It really impacts parents severely. Obviously, depending on when they lose that child, if it was earlier on in life or if it was somebody who's in their teenage or early adult years or even older. So obviously, the older the person is, the harder it is for the parents. The acute grief subsides usually within 1 to 2 months, and then usually people can resume normal function. But if symptoms, if they're gradually decreasing over time, then fine. But if you're at a year and it's as if the person just passed away yesterday, then we're going into it spills over into not so normal grief. Anticipatory grief is when loss is inevitable. So when someone is told that someone is going to be passing away, so it's going to happen with the occurrence of anticipated loss. And again, we see that in the hospital with patients who do not resuscitate. So their families are going through this anticipatory grief. It may increase or decrease as getting closer to the time. So when the doctors say, expect 6 months before, your loved one passes on, closer to the time, symptoms may get worse. So it is important to know what is normal grief, because we're not going to do any intervention for normal grief. But once things start to go a little bit different, then we have to intervene. So it's various forms. So either absent or delayed. I don't know if any of you have ever come across people who just are not grieving at all. So loss of a close loved person and there's absolutely no response or no reaction. We see that, and sometimes it's the person themselves is quite surprised. How come I'm not crying over the loss of my mother? Why do you think people may have absent grief? What is the reason for just absolutely not feeling anything at all? So if anyone has any ideas, so it could be from absent or delayed or prolonged. Now, having suicidal ideation or frank psychotic symptoms is completely an abnormal response. So it is not normal at all to feel like you want to kill yourself because you want to join the person who passed away. So it could be that you're still in shock, brain refuses to admit it, or in denial, sometimes not. So a lot of it is really denial, being one of the main reasons. I've seen times where the person has absent grief because there are others dependent on them for their strength. So it's like that person, again, it's not a conscious thing, but they stay strong because those around them are falling apart. And once those around them start to kind of, start to cope, then that person falls apart. And so they have delayed, actually, grief, 6 months into a year into, when everybody's now on their feet, that person falls apart. Now, kids, again, in the middle of losing a parent, we don't talk to kids usually about death because it's I'm not going to say it's taboo, but it's a very sad topic. So I had this family where they have a 9-year-old, a 6-year-old, and the mother passed away giving birth to the baby. So the most affected child is the 9-year-old. And this 9-year-old doesn't refer to her mother at all. So even though the father on Fridays will, read Quran for the mother, this girl just doesn't at all want to acknowledge. And it's been already over a year. So one of the things is that they were completely avoiding to talk about anything related to the death. So this mother goes into labor and doesn't come out, and nobody talks about anything other than, there's the azza, like the 3 days of mourning. And then this 9-year-old is left to her own, thoughts about what could have happened to her mom. Yet she was told that she passed away, but did anyone sort of sit and actually talk to this child? No, they did not. So the grieving process, she did not mourn her mother. She wasn't given the space to do so. So it's really important. Again, I'm not saying that we involve children, because I had a parent once ask me, can we take the kids to the dafna, to the burial? And that's a bit extreme. I mean, if they're still children, if it's a teenager, it's really up to them if they want to. I mean, they could be given that as an option. But if it's 9-year-old or an 8-year-old or a 10-year-old, I mean, taking them to the burial may not be the most, pleasant at all. Like it's actually quite frightening. It's not going to be beneficial. Let's not say pleasant, but not beneficial to take them through such an experience. But definitely talking about the passing and away, and we already know about how children process death and what is their understanding. So you have to go to their level. People at risk for developing abnormal grief are those who lose the loved one suddenly, or if it's horrific, like a burn or drowning. So these are really horrific circumstances. If that person is socially isolated, so this wife of, been married for 40, 50 years, doesn't have much in terms of social life, kids are far away or may have not had children, loses her husband. So she's already socially isolated. She's at really high risk for developing psychosis or even suicidal ideation. Believing that you're responsible for the death. History of traumatic losses before. So, and we see that with mothers of patients lost to cancer, where she may have lost one or two, children to various types of oncology problems. So that mother is really at high risk, and the father. And if you are dependent, so if you're dependent on the lost one, so like the example I gave of the woman who's been married for a long time and financially and emotionally dependent on her husband, and now he's gone. So she's also at high risk. Importance of knowing that is to pick up these people early and to kind of offer them support. I'm not saying psychiatric intervention, but really offer them support so that they are not isolated. So grief versus depression, you have persistent low mood in depression, you have shame and guilt in depression, suicide ideation and threat with depression, whereas grief is very time limited. Okay, so these are like pointers to kind of tell you in which direction is that person headed. Childhood grief. So children who lose someone significant in their life go through 3 phases, according to Bowlby. So there's a protest phase, which is like being angry, in shock, in denial. Despair is kind of like, again, as the word despair, not really depressed, but it's kind of that sadness or feeling of hopelessness. And I think nothing better describes it than despair. And then they go through a detachment phase before eventually normalizing. So the detachment, I would say that girl we're talking about is probably here, like she's completely detached from, what's going on in terms of what happened with her mother. The parents go through the 5 stages that Kubler-Ross had described. So parents having lost a child will go through 5 stages of Kubler-Ross. All right, so we are done with this lecture. We're going to move on to all right, I'm trying to share the screen. Nope, not this one. Can we see part 1 or is it part 2? Which one can you guys see? Or you're seeing part 2? Okay. All right, so part 1. Can we see part 1? All right, thank you. So we're moving on to, now we're done with completely the normal development. So we've gone from in utero to death, dying, and bereavement. So the next 2 lectures are about theories of personality development. Okay, so it's really trying to give you an overview of why do people become who they are? What makes you the person that you are? Okay. So there's a lot of people, like theorists. So people develop theories that aid in understanding how humans develop in various aspects. And what are these areas that we should explore? What areas of development should we be exploring? How do we become who we are today? So there are so many people who've contributed to theories of personality development, okay? When you go into psychiatry, you will study them all. Today, I just want to kind of give you an overview of some of them. What is the importance of knowing, like when you eventually do psychiatry, hopefully some of you will end up doing so, is when you get a client or a patient presenting with a problem, okay? How is it that you're going to treat them, okay? How would you know what issues, based on your assessment, which treatment intervention are you going to use? And so it becomes eclectic, there were times when people were like Freudian. They only like practiced Freudian psychoanalysis. We're at a different time now where people don't really have 20 years of their life to give to psychoanalysis and trying to understand what the problem is. We're more into like a quicker fix, if you will. So here I'm just going to give you an overview of some. They're just interesting ideas. Again, backed up. Obviously, there are a lot of articles out there to back up these theories. So it's pretty much divided into 3 main groups. There's ego psychology, there's object relations, and self-psychology. And I'm going to go over these in the next hour or so. So the father of psychoanalysis is Sigmund Freud. And Freud, I don't know, have any of you heard of Freud? Anybody saw a movie about Freud, or have you ever watched Woody Allen movies? Yes. Okay, good. So Freud, okay, was actually a neurologist, okay? And he was studying neurology, and he was under the sort of supervision of another neurologist. And what they were, his interest in psychoanalysis came from a specific case, and they called her Anna O. So Anna O was a young woman who came because she had neurological symptoms that developed after the death of her father, and they were more in the form of conversion. Okay? So she couldn't see, she couldn't walk, although there were absolutely no neurological symptoms or signs to indicate why she had these symptoms. Okay, so there's nothing neurologically; she was fine. So his mentor was working closely with her, and so what happened with Anna O is that she then started to believe that she was pregnant. Okay, so she had love feelings for her neurologist, and so what happened was it was a very, very distressing for the neurologist, and so conclusion was that he left her treatment to Freud to figure out what was going on with her. And through working with Anna O, he started to understand and describe certain defense mechanisms that we'll talk about in a bit, resistance, repression, and free association. And so free association was pretty much, you know, when you see in these movies where the client is on a couch and the therapist is in the back, and there's not really much conversation other than, you know, the occasional aha or oh, or like that is free association. So the client will sit and just sort of talk, and so the therapist tries to connect ideas, okay? And there's not a lot of feedback in psychoanalysis, okay? One of the main areas that was a focus for Freud was the interpretation of dreams. And actually, there's a book called The Interpretation of Dreams. And I'm sure a lot of you or some of you may have, you know, come across, you know, telling somebody about your dream and seeing if they can make sense of it, or sitting with your grandma and telling her you dreamt of this or dreamt of that, and, you know, see if she can kind of tell you some things. But there are certain things in dreams that have a specific meaning. Again, that's what at least what my grandma used to say. So if you dream about losing teeth, usually it means someone's going to die. That's what we were always told, okay? And if someone dies in the dream, that maybe means it's long life, okay? He talks about kind of two layers of dream. So there's a manifest layer, and there's actually the dream work. So you have a dream, okay, and you tell it to somebody. So what Freud was saying is that what you say may not necessarily mean exactly what the dream is about. So there's like this manifest kind of what you talked about, but then there's this subliminal stuff in your dreams that he will then interpret, okay? Okay, I'm sorry, I'm just gonna have to take this call from the hospital. Give me one. Hi, sorry about that. All right. So he talks about kind of how dreams can be interpreted. So one of the things he says is something called condensation. So condensation is when you have a dream where bits and pieces of people are put together in one person that looks different. However, their nose could be similar to the nose of your, primary school teacher. The eyes could be like the eyes of your, friend in grade 1. So when kind of things come together, but when they are condensed, they don't make sense. But when they are kind of pulled apart, they do make a lot of sense. Okay, so again, imagine somebody sitting on a couch and telling Freud their dream about this person, and then Freud would say, well, maybe describe this person. And so you would describe this person, and so he'll be like making these associations between, what does it mean to have this condensation? Displacement is another thing that happens with dreams where, and he's very fond of something called murderous rage. So murderous rage is when you feel so negatively to somebody that's so close to you that you want to kill them, but obviously you don't. And so what happens is that this anger is displaced onto somebody who's completely neutral. So in this dream, you are, choking somebody, or you are hurting somebody that has never done anything at all to you. Okay, so it's this displaced anger or rage onto something that's neutral, because it's really hard for us to imagine that you're actually hurting somebody that you actually love. All right, so that's displacement. Symbolic representation is, again, parts of the dream that are symbolic to, and again, Freud was, a lot of his theories were based on sexual drives. So in the dream, there could be representations of things that could refer to sexual drives. Okay, so you'll be describing, a scene, you saw a scenery in particular, and then he would make the connections, usually going back to sexual drives. Secondary revision of dreams. So primary process thinking is he describes as thinking that is very disorganized and uninhibited. Okay, so having kind of wild dreams, wild thoughts that maybe don't even make sense. Okay, and then these are kind of then organized in secondary process thinking. Okay, it kind of is, it's making sense of the nonsense. That's what secondary process thinking is. It's trying to make sense of things that just are kind of not really making much sense. You'll see that Freud over time keeps changing how he tries to understand humans. Now, what does that mean? Does it mean that he is just always experimenting, or is it just because humans are so complex? So humans are so complex so that once he figures out something and he starts to apply it, he will encounter people where it does not fit. So that theory just doesn't make sense with that particular person or that particular problem. Then he starts to think about, okay, well, what else? Okay. So he talks about dreams and trying to interpret them. And then he talks about something called the topographic model of the mind. And so he divides the mind into 3 levels or layers, and these are not really anatomically correlated. So we don't know where the conscious part of our brain is. Is it the forebrain? Is it the midbrain? We don't know. Okay, but it's a function. So the conscious part of your brain is the part of your brain that you are always aware of. You are aware of who you are and what you're doing. So that's the conscious part of your brain. The unconscious part of your brain, and I'm sure a lot of you have heard, it's in, the unconscious mind. Okay. So it's that part of your brain or, again, not anatomical, but where you have no access. So stuff is filed in your unconscious mind, but you don't know what it is, and you don't have access to it, and you may never have access to it. Okay, and the preconscious mind is the one in between. So it's the interface between conscious and unconscious. So your conscious mind is a part of your mind where perceptions coming from the outside world or from within your body are brought into awareness. So it's the part of your mind that just, is in your day-to-day dealings. Okay, and you can communicate it by language or behavior. So that's your conscious mind. The pre-conscious are the mental events or processes that can be brought into conscious awareness by just focusing your attention. So, your primary school teacher, that's 15 years ago for some of you. What did he or she look like? Okay. So if you start there and try to really focus your attention, you may be able to bring bits and pieces from maybe your unconscious mind into your conscious mind, again, by focusing. So it's the interface between consciousness and unconscious parts of your mind. And it's actually a barrier, okay? It's there to censor. Again, like I said, Freud talks a lot about wishes and drives. And so these unacceptable wishes and drives, usually of sexual content, are kind of like packed in your unconscious mind. And your preconscious mind is kind of like that protector. It's this barrier that makes sure that none of your unconscious stuff surfaces, okay? So the unconscious mind is where the mental contents are kept from conscious awareness by repression, which is a defense mechanism. The content here is limited to wishes that are seeking fulfillment, and it's really characterized by primary process thinking. So your unconscious mind, primary process thinking, meaning that it's just very disorganized and it's very primitive, okay? And usually governed by the pleasure principle. So it's things are in your unconscious mind, or like anything and everything that you want to do, but you're not really supposed to do. So the Freudian theory suggests that sexual libido is sort of what controls behavior. She's a child. Now, Anna O was not a child. Okay, so Anna O was a young adult. Okay. And so she developed these symptoms after the passing of her father, and that's what we call conversion. But then she started to have feelings for her doctor, and that's really what it happens when you're in psychotherapy. So this doesn't apply to children. Again, we'll talk in a bit about the psychosexual developmental stages described by Freud, and then we'll answer that question, okay? We say it's a dynamic system because your unconscious mind can be brought to conscious awareness. So there is a level of transfer. So there's transport between unconscious and conscious, depending on, so sometimes people get into hypnotherapy. So hypnosis, the objective of is to, loosen up the preconscious, so things from your unconscious mind can come to surface. And there's, again, reasons why people do hypnotherapy. It's for certain problems. So the limitations of this topographical model of the mind is he then kind of stumbles into defense mechanisms. So defense mechanisms make it more difficult for access of the unconscious mind. As well as this, there's an unconscious need for punishment that he then talks about. And so these limit this kind of theory that he had talked about. Also, that we learned that there's a tendency to regression. So humans have a tendency to regress. There is also an importance of wish fulfillment, like you want to fulfill your wishes, as well as, process thinking, primary or secondary. So this moves him on to what he calls the drive theory. Okay. What does unconscious need for punishment mean? So sometimes people will have symptoms. For example, again, like with Anna O, she couldn't walk, she couldn't see. So she had these symptoms that were really incapacitating her, okay? So his theory was probably that there's an unconscious need for punishment. Like it's as if like the body is trying to unconsciously punish her, okay? It's really complicated. I don't know if it will be easy for me to explain, but if you eventually get into psychiatry, you will understand it more. But sometimes, why do people have these symptoms that incapacitate them and cause dysfunction? Okay, so he describes it as if there's an unconscious need for punishment, as if you're trying to hurt yourself, but not at a conscious level. You're unconsciously trying to hurt yourself. That's his interpretation of it. And that's why he found that it was maybe difficult to treat some of these people with conversion, because it's as if their unconscious system wanted to hold on to these for a need for punishment. Okay, it kind of sounds a little bit sadistic, but that was his interpretation. Okay, so his drive theory is kind of like this, the hallmark of Freud. Okay, so instinct is a species-specific behavior. So part of our instinct is what are our instinctual needs? Okay, so to eat, to breathe, to have children. Okay, so these are like instincts that are instilled in us, and it's for the purpose of continuity of species. So there is, if we're not going to eat, if we're not going to breathe, we're not going to drink, if we're not going to have, other species like, procreate, have more of us, we're going to be extinct. Okay, so these are genetically derived, and they're really independent of learning. Okay, we're never taught that we need to eat or breathe. It's part of our instinct. So the characteristics of instincts are 4. So it kind of has like 4 parts. There's a source, which is, the organ from where the drive comes. The impetus is the amount of energy or force. The aim is what is the objective, all right? And the object is the organ that needs to be satisfied. So, for example, you feel hunger, all right? So the source is your stomach. How hungry are you will then dictate the aim, which is, are you going to get up and make a sandwich or are you not? And the object eventually is to satisfy hunger. Okay, I want to make sure that, I don't have these hunger feelings in my stomach. This is at its most simplest form to explain. Okay, but those are the characteristics of an instinct. Okay, so impetus is the energy, the force. Okay, so how hungry are you? So if you're really hungry, you're going to get up right now and make a sandwich. If you're not that hungry, you're not. Okay, so it's really the force or the energy. Now, you're going to refer to your PDF for this, okay, because there's tables that you need to actually go through, right? So he talks about 6 stages of psychosexual development, and he's divided them based on age, all right? So he talks about the oral age, so it's from birth to around a year or a year and a half. The anal stage from a year and a half to around 3 years. Okay. Then he has the urethral stage. Okay. It's kind of in that around the age of 3. Then you have the phallic stage, which is from 3 to 5. The latency stage from around 5, 6 to around 11, 13. And then the genital stage is from 11, 13 onwards till later in life. Okay. Now, for every stage, he talks about the definition, and then the description, the objectives, pathological traits, and the character traits, okay? So I will need you to go to your PDF for that, but I'm just going to give you an overview. So we said the oral stage is from birth to around 12 to 18 months, okay? So what is the main objective of humans in that time? What is the main objective? Like, what is our function in that time? What do babies do in that time? Okay, so survival to eat. So it's feeding, right? So feeding, and we're talking, pretty much about breastfeeding. Thank you. So the breastfeeding experience, okay? So here, the basic needs of infants are to eat and to be fed and to be cared for. Again, if they're wet, they're chained, but specifically we're talking about the feeding experience. And so the description here, he really focuses on the oral zone. Okay, so the mouth. So when kids cry and they're fed on demand, what does that make them feel about the external world? So you cry, you're hungry, you're fed. Versus you cry, you're hungry, you may be fed or may not be fed. So those are 2 different experiences. Or the third experience is before you even cry, you're fed. So you're fed like all the time. So you have somebody who is fed when they need it, somebody who is stuffed, and somebody who, even if they need it, don't get it or may not get it. So not very kind of organized. So someone says about safety, you want something, you get it, okay? All right. So in these three scenarios, you can have different outcomes, but the objective here is really to develop a trusting relationship with the world. Because when I cry and I'm fed every time, so therefore I know that when I need it, I'm going to be receiving it, so therefore there's a trusting relationship between me and the world. I still don't know that this world is my mother. Okay. I'm still a month old or a few days old or 2 months old, like in the videos we saw before, starting to, by the age of 3 months, have a bit of visual acuity and starting to understand that this person that attends to me is someone important in my life. But again, in this oral stage is where you start to develop that sense of trust with the outside world. Okay. Now, somebody who is, when they're hungry, they're fed, that's a trusting relationship versus somebody where when they cry, sometimes they're fed, sometimes they're not fed. So they're not going to have a very trusting relationship with the world because the expectations are kind of skewed. Sometimes it happens, sometimes it happens. So I don't know if I really can trust this outside world. And then you have somebody who is overfed. So it's like they don't even get a chance to kind of, even feel hungry. So this is somebody who may then, again, when you try to understand what are the pathological traits in that scenario. So you can have somebody who is really not trusting at all of the world, or somebody who's completely entitled because, everything is always there. Okay. So you can get these outcomes that vary based on a very simple process, which is just breastfeeding. Okay. So you want people to come out of the oral stage, okay, with an ability to give and receive. So I'm able to give and receive because I have a trusting relationship with the world. I'm not going to be somebody that takes a lot because I don't trust. So I want to make sure that I have, or somebody that, is just like, overly entitled because they've just always had without even asking. Okay. So let's say the normal outcome of the oral stage is to have a normal trusting relationship with the world. Now, obviously kids continue to grow. All right. Sometimes you finish the oral stage, but you haven't really finished its developmental requirement or psychological requirement. So you finish oral stage because now you're a year and a half, you're going into the next stage, but you don't have a trusting relationship with the world because you were not fed, in that proper way, right? Now, it seems very concrete. So when you meet somebody who doesn't really trust the world, if you're Freudian, you're going to start to think about their early, experiences with parents, but I mean, we're not going to ask a 30-year-old or a 20-year-old, what was your breastfeeding experience? Because obviously it's not something you're going to remember. All right. But again, with Freud, it's more like, people who have that kind of pathological traits most likely had issues in their oral stage. Okay. And again, we'll talk later as to what is the relevance. Okay, so you figure out someone has problems with their oral stage and pretty much all stages. Then what? What are you going to do with that person? Okay, so here we're trying to understand why can some people have issues with trust. So then you think, okay, maybe problems with the oral stage. You go on to the anal stage. So what is the objective of this? So, somebody who is a year and a half to 3 years of age, what are some of the important milestones in this developmental age? What do you guys think? Okay. So here we're talking about toilet training. Absolutely. So this is we're going to focus on the toilet training. Okay. So toilet training is one of the sort of milestones, and that's why he calls it anal. All right. So here it's really talking about the maturation of sphincters. So if you're looking at it from a biological perspective, so the definition here is maturation of sphincters. Primarily, again, we're talking about like anal control, right? And so what happens here is it's really quite, I don't know if any of you have younger siblings. And if you've ever heard or seen your mom try to potty train, it's a very difficult time for mothers because it's challenging. And it could be challenging because of variables, whether it's related to the mother or actually the child. Okay. So you have parents who are really harsh about potty training, okay, and you have parents who are very lax, kids can do in their diapers whenever, and you have the in-between, which is what we would say the norm, okay. So you want to have in this stage, give them a bit of independence, because that's kind of what it's about, is struggling to be independent and to control your own sphincters. So to go potty when you want to go potty, or not go when you don't want to go. So it becomes a bit of like a back and forth dance or fight. Okay. So a good, like good enough, let's say mom or parent will give a bit of space, but not where, kids can be, pooping in their diapers and never cleaned. Okay. You want to respect that balance between giving them that independence, but also giving them structure. All right. So if you're overly harsh about the potty training experience and you're like judgmental and negative, okay, you're going to have kids that are really inflexible and rigid. Okay. And I don't know if any of you have heard of, it's a lay term, but when you tell someone, why are you so anal? What does that mean? When you tell someone, like, why are you so anal? What are you referring to in terms of their personality when you say that? So not flexible, really, and uptight. Exactly. So I haven't heard that before. So this is a lay term, okay? And it really means that someone's really inflexible and so uptight, very rigid. Okay, and so people around them will tell them, like, why are you so uptight? Why are you so anal? And so usually people with that description have had, according to Freud, harsh parenting around toilet training. The extreme opposite would be somebody who's extremely sloppy, messy, okay, as a personality, just because in their anal stage, there was just absolutely no structure. Okay, so there's zero structure. And so you get that extreme end. The objective here is pretty much to become independent and to go towards being separate from your parent, your mom, in a healthy way. So that's really the objective. Pathological traits that come up here based on that experience are either being super inflexible and rigid, or being super sloppy and messy, okay? And so the successful resolution here of this, so healthy character traits are people who are, independent, okay, and autonomous. So it's really striving for autonomy and independence. So you're neither the inflexible, rigid, and so that's one end, or the very sloppy and messy, which is the other end. All right. So how does this correlate to toilet training? So they say, okay, got it. Okay. So the potty training obviously experience. So some of us who are like super rigid and inflexible, okay, again, really hard to bring somebody in their 20s and say, what do you remember about potty training? Okay. So it's not the objective. But when you do see somebody with those character traits, then you kind of go back to maybe that was a very difficult experience for them. Maybe they had really harsh parents that didn't give them space to be autonomous, didn't give them space to be independent. And so they came out being so inflexible and rigid, okay? The urethral stage for Freud was kind of like he left it in between. It wasn't really his focus, but it's also around, obviously urethral being around sphincter control. And it's around, being, again, mastery of skills and being more autonomous. And the objective here is, again, to have control and to be independent. Now, pathological traits, he talks about, people who are being competitive. So competitiveness as part of being, overly controlling, to be in control, and so therefore being super competitive, or just not being competitive at all, like, being extremely passive. So a healthy outcome of this is people who are, again, because they've had a healthy anal stage of being autonomous, and here being competitive in a healthy way, not in a pathological way. Okay, so now he paves way to the next phase, which is the phallic stage. So this is the hallmark, really, of Freud. Okay, so here we're talking about children age 3 to 5. All right, and again, he focuses a lot on sexual drives within this stage. Although we know, 3 to 5 years of age, children logically still have no hormones. Okay, so I want you to kind of be super open-minded to understand what I'm going to say. All right, so in this stage, he talks about something called the Oedipus Complex. Has anyone ever heard of the Oedipus Complex? Has anyone ever come across that term? Oedipus Complex. All right, yes, so at least some. Okay, so the Oedipus Complex, just a second, is really talking about triangular relationships in life, okay? The first triangular relationship in your life is going to be between you and who? Who are the two other people in this triangle? Okay, who are the two other people going to be in this triangle? Okay, your parents, yes. So he talks about this complex. So it's a triangle between child, mother, and father, right? And he describes it differently for boys and differently for girls. So let's start with boys. So the Oedipus complex for boys is where the boy, it's a competitive relationship for mother's love, okay? So there's going to be what he calls, like the son is striving for love from mom that he wants, that dad will not get, okay? If you try to, again, understand that, a 3-year-old having that kind of a complex, thought process doesn't make sense, but that's how he interprets triangular relationships later in life. They go back to issues in the Oedipus complex. So what happens is, this boy is kind of wants mother's love, but then he talks about castration anxiety. So a father will then castrate son. Castration is obviously removing genital area, because it's kind of like a punishment for how dare you compete with me for mother's love. And so what happens is, because of that castration anxiety, and that this young boy is so worried about, losing that. So then he then starts to not focus on mother's love, but focuses on, I want to find someone else like mother, right? So you will find that some men, as they get older, want to marry somebody who, has same characters like his mother, cooks like his mother, and I don't know if that's something you've ever heard or kind of come across, but Freud would then explain that by this Oedipus complex, that because he cannot get his mother sexually because of castration anxiety, so therefore he moves that energy in trying to find another woman who is, maybe similar to mom. Okay. Now for girls, it's different. So for girls, it's the complex becomes between, envy. Again, it's for mother's love, right? For mother's love. And so she has a penis envy. So, had I had that, then mother would love me as much as she loves dad. Okay. So for girls, he says they have a penis envy. Okay. And so the outcome for girls was a little bit different, maybe more complex. Okay. So resolution for boys is castration complex, and then identification with the aggressor, which is, okay, identifying with dad. And so now I'm going to go look for somebody like mom. I will not compete with my dad for my mom. For girls, he called it the Electra complex. Okay. That girls feel castrated. They have a penis envy. Again, It's really too Freudian, right? And so he says that women have a genital inferiority, and so they have three outcomes. You're either going to be of normal sexuality, you kind of come to terms that, hey, it's okay, right? Or you're going to be hyper masculine, and so like more of a tomboyish kind of thing, or you're going to be asexual, like forget it, don't want it, okay? So usually the fear of somebody's mic is on.
I'm here. Why don't you get a little cup of water?
If somebody's mic is on. So fear of loss of mother's love usually leads to the resolution. So boys, girls do not want to lose mom, right? And so it will be sorted out, however, so that eventually they don't lose. What about children of single moms? I mean, there's always going to be who's castrating who. Dad is castrating, of course, to identification with the aggressor. So if you're going to compete with me for your mom, I'm going to castrate you. Okay, so it's identifying with the aggressor who is the father. So because boys feel like, this castration anxiety, so they're not going to get into that competition with dad. So they move on to find another, female who could be like mom. So girls compete with dads for mom's love, okay? So she feels that if she had a penis, then, then it would be, she would have mom's love. So it's always a competition for mom's love, okay? But again, the resolution, I think for girls, it was like he wasn't, I think he was kind of lost with girls. He came up with this electro complex. But again, whenever we meet clients who have issues all related to triangular relationships, and it's always about competition for, who's going to be the favorite. Even in your own friendships, you're your best friend, you and your best friend, okay? So the two of you, again, we're not talking about, sexual things like Freud is referring to, but we're just talking about like, you are best friends. Comes in a third, you're now three. I'm sure you have encountered that sense of like a power struggle. Who's the favorite of who? We were best friends, and now this third comes along. Now, it becomes like a dynamic, and it's a struggle. So this is a triangular relationship, okay? In terms of, the struggle for my best friend's love, again, not necessarily meaning it in that way, but, our friendship, okay? So I'm sure we've all gone through that. Does that all mean that we've had problems in the Oedipus complex? No, it does not, because again, we always find ways of resolving. And if our life is all about triangular relationships, then we have a problem. Doesn't this not stem from sexual desires and more just feelings? Yeah, it's feelings. But I'm saying that Freud's theory was all about libido, repressed sexual needs. Okay, that's his theory. I'm not saying that any 3-year-old or 5-year-old will come across is going to be thinking that way. But what we're saying is we're giving you, we're given frameworks to work with. Should we meet clients in life who are struggling with certain things, and then we understand different theories, we can apply, maybe it's related to that. And I can do some work with my client around trying to understand, why do they always have issues? Why do they always get themselves into these triangular relationships? Because again, you're not going to remember, back in when you were like 3 years old. But I'm telling you, I have a patient, she's a 14-year-old patient brought to the clinic by her father because she's suicidal. Okay. Now, in trying to understand this, suicide and depression, so she does have clinical depression, but also there is a triangular relationship where she and the father are on the same page, and the mother, for whatever reason, is just the outcast. Okay, so it's a triangular relation, mom, dad, and daughter is competing with mother for father's love. It's very basic, but he spends time with his daughter, he goes coffee with his daughter. The wife is not in the picture. Okay, so it's almost like this daughter has replaced the wife. Okay, so this is a triangular relationship. So this girl feels unloved by her mother because the mother feels threatened by this girl, because now this dad is really just spending more time with his daughter and not so much with his wife. So the wife is extremely angry and she's projecting. So she's kind of like, this anger is projected onto this girl, and the anger is really with the dad. Okay, so now this girl is now the focus of this anger between the two of them. So this is a triangular relationship. Okay, so I was discussing this with my residents that, if we're going to think about Freud, it would apply to this circumstance because it makes sense. Okay, now we're not saying that there's a sexual relationship here between the father and the daughter, although, sometimes we also have to put in the back of our mind, because we do come across sexual abuse, we do come across incest. Okay, so it's something, it's kind of like a bulb that I have, a light, something to investigate, something to look into, because the relationship is not normal. Okay, so a healthy outcome for the phallic stage is that you have, again, according to him, you come out at the age of 5, at least having a good understanding of your gender identity. Okay, you know that you're a girl, you know that you're a boy. So it's a sort of an emerging sense of your gender identity, your sexual identity, and not a lot of shame and guilt. Okay. Moving on to the latency stage. So he talks about, up to around the age of 5, 6 to around 11, 13. So what are the objectives of this age? So 6 to 12, what are your milestones? You're here in grade 1 to 6. So what is, our relationships and, the sexual drives, as according to Freud, at their foremost here? Or again, then the word is latency. So it really implies that it's not about the drives anymore as much as it's about personal competency. So let's see. So it's education, school. So this should be resolution. Not really. No, not yet. Resolution, still not yet. So here it's kind of a stage of latency for your drives. Okay. And so here it's about more of your functions within a group. So that's kind of the description of it. And the objectives here is to really consolidate your sexual identity, your sexual role. And again, there is a bit of competition, and the focus here is on development. Okay, developing your interests, like learning, peer, how you function within a group. And so you want someone to come out of this, so that the normal or like healthy character traits is somebody who is able to function well within a group, somebody who's able to make more sound decisions. Again, you're going from pre-operational to concrete towards formal operations. So like, closer to age, you're going towards more formal operations of how to manage your life in terms of your cognitive thinking. And then he moves on to the genital stage, and that's from around 11, 13 onwards. So here it's adolescence, and so it's hormones, okay? So it's more about again, here we talk about gender identity, identity crisis. So this is when it happens in your early teen years. And so the objective here is really to have complete separation and be autonomous, because now you're embarking on adolescence. So you have to have like this sense of separation from your parents, as well as having like more mature relationships in your life. Okay, and so basically you want to have a full capacity, okay, to kind of understand yourself in terms of gender and sexual role, to then kind of move on. So this is kind of where you have it or you don't. So when we see people with gender identity issues or gender dysphoria, it's usually around this time, so early adolescence, where things are not clear to them, and it usually again is going to stem from issues all along. So, if you have somebody who has problems with basic trust, and then they never had a chance to kind of really be autonomous, and then they get into their phallic stage where they get into these complex triangular relationships where, again, their gender identity is not clarified. And then they move on to the genital phase where, again, things are not yet more clarified. So you then meet somebody who's in their 20s and they're kind of still confused. So you can work backwards, but you have some kind of basis as to maybe where did things go wrong, or how was it, in terms of parenting. Like I said, a 20-some-year-old, you're not going to remember everything your parents did with you. Okay, but you're going to have a collective feeling. You're going to have a collective feeling of, I had a great childhood, or I had a terrible childhood. So I'll ask you, well, what made it terrible? You're not going to really remember, well, on this day my mom did that, or on that day my dad did that. But it becomes a collective sort of accumulation of things that gives you a general sense of how it was for you growing up, whether it was great or whether it was not so great. And a lot of us who have not had such a great, time growing up and collectively feel it was not a great childhood. You may have some ideas about, okay, when I have my own kids, I'm definitely not going to do this or do that. But do you think that what you want to not do, you will actually avoid doing? Do you think that we kind of, when we make these pointers, I'm not going to do this, I'm not going to do this, because that's what my mom or my dad did with me, does it mean that you're not going to do this with your own children? What do you guys think? So usually you do, okay, but hopefully not. But why do you think you usually do? Because you have a tendency. Yeah, because as much as you don't want to consciously, okay, you make a conscious decision of, I'm not going to do 1, 2, 3, but you're really driven by your unconscious sort of mind, okay? And that unconscious mind kind of makes you do things and you're not really aware that you're doing them unless you have the insight, and then you catch yourself and you're like, oh my God, I'm like my mom. I'm sure some of us have had that. Oh, I'm like my mom, or I can't believe I'm doing exactly the same thing that my dad has done to me. So it's this repetition, and it's really a very unconscious thing. So when I see, parents with their kids, I was just telling my residents yesterday. So part of the assessment that we do is we want to ask these parents about their own parenting. Okay, because when you do things with your kid, like children are not born with a manual. I mean, that would have been amazing. It would have been so easy, like, turn on, turn off. What do you do? How do you raise children? If it came with a manual, but they don't. So you raise children really based on how you were raised, okay? And it's a very unconscious process. So if you were raised and you are a loving and caring person, so something has, something in your childhood kind of went into making you that way. So probably, you have a very trusting relationship with the world. You were able to be an autonomous, and were given the space to be an independent person. You were not judged because you had a good enough mother. And so again, this is Freud going in with Winnicott. So all of these people who talk about theories, we understand into how does it make you the person that you are, because you're a very loving and caring mother. Okay. So that means that all went into your making, okay? Because you were giving all these opportunities by another, very loving or caring mother, right? But what if you didn't have that experience? Does that mean that you're going to not be a great mother just because you didn't have good mothering? Obviously not, because it all depends on insight. So if you have insight into, you catch yourself that you're doing things with your child that you do not like, then you seek help. Right. And when you do seek help and we sit there and discuss with you what your parenting was like, what was it like for you growing up as a child, then you start to understand, you see pattern, you see trend. And so then you start to figure out how you want to make a change. So it's really a very proactive process. Okay. But unfortunately, we do see parents who continue to do things that are not entirely great to their children, how do you help them? You can only help someone if they want to be helped. Okay. You cannot treat someone who does not want to be treated. You cannot help someone who doesn't think that they have a problem. Okay. So moving on then, he then talks about ego psychology. So that's another phase of his, after he has looked into the drives and the psychosexual development, he looks at ego psychology. So he talks about three things, which are the id, the ego, and the superego. Okay, conscious parenting would avoid repeating patterns, but most people get too busy to be conscious. That's absolutely, and you go on to autopilot. So autopilot is really your unconscious mind, okay? They're not the ones suffering if they don't think they have a problem. The children do, yeah, but we always say that the child is a symptom of a problem. So sometimes people bring in children, the child has no issues. The issue is the parents. So they're like the tip of the iceberg, okay? So if you don't go in because you don't think about you have a problem, you think your child has a problem, then we work with you, and then eventually you come to have more insight that there's nothing wrong with your child. The problem is you, and you need to get your own therapy. You need to go get your own business sorted out, okay? And actually, we have a lot of success stories, parents who really turned around, because at the end of the day, you love your child. There's no parent who does not love their kid. So that's the strongest motivator to improvement. Now, you need to get better for your own child. That beats any other motivator. So it's not about your job. It's not about your relationship with your partner. It's about your child. So it's super powerful. It's amazing. It really drives people to change, because at the end of the day, you want to have the best. We all wish our children are better than us. Okay, so that becomes our motivator. Okay, so the id, the ego, and the superego. So the id is usually the part of us, according to Freud, okay, that, you can visually kind of imagine it. So you've got when you're growing up, your mom will tell you, there's someone here on the right side that tells you to do good things, and there's someone on the left side that tells you to do the naughty things, okay? So that's kind of figuratively saying. So the id is a part of you that wants you to do the naughty things, the bad things, the things that people won't approve of. So that's your id. Your superego is your moral sense, your ethics, your religion. So that's the part of you that says, no, you can't do that. And so it's that you have a struggle between the id and the superego. Now the ego, okay, is the part of you that controls and regulates the drives, okay? It's the part of us that, makes judgment. It does reality testing, okay? It tells you, okay, this is real, it's not real. It's the part of us that relates to objects. Objects, obviously, is, people in our lives, okay? But it has, again, synthetic functions. So the synthetic functions of the ego are like things like organization, coordination, okay, of information, management of data. Data is like, stuff that So that's the synthetic function of your ego. It also has autonomous functions. He talks about primary autonomous functions and secondary. So your primary autonomous functions are things like your perception, your learning, your intelligence, your intuition. So these are things that really you have nothing to control. Like it's just maybe genetic, pretty much, your intelligence and how you process information is not something that you have much to do with. It's just you either have it or you don't, or it's either high or it's not, okay? Then your secondary autonomous ego functions. He talks about functions or behaviors, okay, that serve as a defense, okay, that then become really independent of them. And so I'll give you an example. So a child who has a lot of anger, okay, and then that anger is repressed, okay, because it's not allowed to be. And so it's not okay for me to hurt other children. Okay, I can't be going around beating up other children. So that is repressed and replaced with, I should be more caring. I should be more, loving. Okay, so you repress that second, like that sort of anger, and you start to do forcefully, like, because I'm going to be punished. If I'm going to hurt these kids, I'm going to be punished. So I better be nice to these kids. So I'm doing it not because I want to, but because I have to. This kid can then go on later in life, okay, where that defense mechanism becomes replaced. And so that person can then go on to become a social worker, all right, who then, out of the love of doing good for others, is now doing good for others, not because they have to, but because they want to, okay? So that he calls a secondary autonomous ego function. So how it is that when we're young, we do things because we have to, but then later on in life, we do things because we want to. So it's that transformation, okay? And it again goes to support, when we talked about levels of moral development, where earlier on, it's because you fear punishment, but later on you do it because it's something that you want to do, not because you have to do. So these are all ego functions. Now we're going to move on to defense mechanisms. And again, you have to go back to the PDF, okay? Because you need to read the specifics of all these defense mechanisms, okay? So these are not things that we do consciously. Right? So your defense mechanisms are there in place to protect you, okay? To save your psyche from kind of falling apart. So very unconscious things that we do. So when you get into therapy, usually the therapist tries to figure out what these defense mechanisms are, because as much as they could be protective, but they could also be very limiting and causing you dysfunction. So they protect you, but they don't allow you to function normally. And so you're going to have some dysfunction. And that's the reason you go to therapy, because there's a problem. And when your therapist is trying to sort that out, they come across these defense mechanisms that they try to work with, okay, and eventually try to resolve, so that, when they do so, whatever issue that you have will surface, and then you can work with it and hopefully resolve it, okay? So Valent describes or classifies 4 groups of defense mechanisms. So there's a narcissistic group, there's an immature group, there's a neurotic group, and there's a mature group. Now, obviously, we kind of strive to wanting to have more of the mature defense mechanisms, because these are not going to be limiting to you, okay? They're actually liberating, or actually allow you to develop, okay? But we may have bits and pieces from every group. Like, we all have defense mechanisms. There's no way that you don't have defense mechanisms. Now, whether these defense mechanisms are at the forefront and they're so incapacitating, or they're not so at the forefront and they're kind of, there, but, you're functioning pretty okay until some sort of situation happens where, it kind of alerts these defense mechanisms to, get into action to protect you. Okay, so it's a kind of a mix and match and very dynamic. So this lecture has already been uploaded on Moodle, but I have added things to these defense mechanisms. So please make sure that you make note of them, because you'll find that I've added extra things that are not in the originally uploaded lecture, okay? So for those of you who are not attending today's lecture, please, can you tell those who didn't attend, so that they don't just rely on the uploaded lecture, okay? So the first are the group of narcissistic, okay? Can you upload this? I don't think we have time. Just make a note, please. I just added a few words. You just have to make sure that you copy them, okay? Because your exam is on Tuesday, so we don't have time. All right, so the narcissistic defense mechanisms, okay, are denial, distortion, and projection, okay? So denial obviously is, let me just see. Can you send it here after the lecture ends? I'm not sure how I can send it here. It's a lot simpler than you guys are making it be, okay? So you just make sure you write it down. So this one is similar to I didn't add anything here. So these narcissistic defenses are the same as those in your uploaded lecture, okay? Just a pencil and paper and write down. It's not going to be hard. So denial is really avoiding the purpose of denial, remember when we talked about death? So you hear that someone has passed away, or somebody was told that they're going to die. So it's a denial, right? You're like in denial, and it's really avoiding. The purpose of it is to avoid awareness of something that's really painful. Okay, so it's a painful aspect of reality that is kind of kept away from conscious awareness. Now, we all have denial. We all go through phases of denial. But when I'm saying that it's a narcissistic defense, there are people where denial is really everyday type of mechanism for them. So they're in denial pretty much all the time of everything. Okay, so that makes it abnormal. But when you are in denial of a specific problem, okay, and your friends are like, what the hell is wrong with you? You're in such denial, okay, because they realize that there's a problem. But this is an occurrence. This does not make the way that you go about in life. So that doesn't make it abnormal. But when it is the way you go about in life, then that is abnormal. Okay. So distortion is something that we see with psychosis, where reality is sort of distorted or reshaped. So reality is reshaped, okay? And it's done so to suit the inner needs, okay? So things are distorted to suit me internally. Again, I'm not consciously aware of this, but I distort reality so that I feel okay. So it's actually protective, but does it affect my life? For sure, because I'm not like living a reality-based life. Everything's distorted. Everything's out of scope, out of context. And it's sort of one of the mechanisms that we see with psychosis and delusions. Projection is one that we see with personality disorders, okay? With borderline personality, you're going to take that, I think, in psychiatry. I'm not sure if you've already can take it this year or next. I'm not sure. But it's one of these defense mechanisms where it's a lot easier for me to blame the world than it is to blame me. So there's nothing wrong with me. It's them. Okay. So I'm not the cause of the problem. They are. And so I project onto them, all my dissatisfaction. Okay. So I have these unacceptable inner impulses. Okay. Very difficult for me to deal with the fact that I'm a problem, that people don't like me because of something that's wrong with me. Okay, so it's a lot easier to say, there's nothing wrong with me. They are the problem. So they project onto the outside world their inner insecurities. Okay, how can we help people with everyday denial? Okay, it's not normal to have everyday denial. So that person is not someone that you can help personally. It's someone that you can actually maybe suggest that they seek help. Because part of the issue is for them to identify that this is how they're functioning. Okay, and that's what the therapist does. But again, if you walk into my office and I know that this may be your problem, okay, or you mention it, everybody says that I'm always in denial. Okay, so your friend goes in and says, hey, everyone says I'm always in denial. Okay, so we have to examine this hypothesis. And this examination comes based on, their life. So we have a session today and then they go about their life and I see them next week. They come in next week and they talk about the events of the week. Okay, so my job is to then see how I can connect the dots so that over time I can make them realize or bring to their conscious awareness, maybe this is what it is, or what do you think about that when they describe an interaction that they've had or a response that they've had. So resolution or improvement will come when they start to identify that this behavior is actually called this or that. So that's one process, is identifying it. But then the other part of it is well, how do you overcome it? How do you not do this anymore? So I'm kind of describing it in the most simplistic of ways, but honestly, I'm telling you, these kind of things take years in order for people to actually come to that realization and come to that conclusion. Not easy. Okay. So we move on to immature defenses. I've added here to your current existing uploaded lecture, I've added introjection and somatization. They're going to be in denial of that too. Yeah. So if I say it, this is an elephant, or we call it an elephant, and he sees that it's an elephant, he can still say, hey, but it's still not an elephant. So it does take time for people to actually come to terms with and understand behavior. It's not that easy. So acting out is an immature defense, okay? Who do we see usually acting out? Like, we see acting out in, so it's like having a temper tantrum. So, your 3-year-old wants extra M&Ms, you don't give them extra M&Ms, so they kind of like get on the floor, scream, and, have a temper tantrum, and they're acting out, okay? We see adults act out, or is it just kids? Do adults act out? Yes, they do. Okay. Can someone give me an example? Like, how is it that adults act out? Okay. I'm going to explain acting out. So basically, you express these unconscious wishes by behavior because you don't want to be conscious of it. Okay. So this is somebody whose response is way above and beyond the actual need to be. Okay. So it's really hard for them to deal with this internal feeling of that they failed or they did something that was not good. And so they kind of act out, they're angry. And so the energy goes into this behavior and it takes away from them feeling that they actually did something wrong. Okay. So we do act out sometimes, when you're stressed, when you're, going through, when you're under a lot of pressure, you can act out, but it's not normal for you. So when you're provoked, okay, it's like, I'll be the child today. Again, these are not conscious. Okay. So, it's not like a switch on, switch off. Today, I feel like I need to act out because I'm like really stressed. It's not like that. It's when you're provoked or pushed, you're stressed because of an internal turmoil that you have. It's not because something happened. It's not like, there is an accident and so you're acting out. No, it's usually because of some internal struggle that you have, internal thoughts or feelings that are difficult for you to kind of contain. And so the energy goes into like the acting out, okay? And it helps you to kind of relieve that tension. Okay. Blocking is a temporary or transient, and you kind of inhibit thinking. Okay, so it's blocked. You kind of get a block where, for a short period of time, it's just like it's not there anymore. Okay, it could be protective again because you're stressed. So blocking again, we're calling these immature defenses because maturely we don't block. Maturely we deal with. Okay, I have a stressful situation. I learned how to cope. I know how to cope, and so I don't have these immature defenses working for me, because I have more proactive ways of dealing with my stress, okay? Blocking happens in exams, right? Because you're stressed, it doesn't mean that it's an immature thing, but it happens. Is blocking pretending that a problem did not exist is denial. So blocking is not denial, okay? It's sort of for a period of time where something's just not there. Sometimes in an exam, you'll say, I had a block. I just can't remember anything. Everything's gone. All right. So it's just because of the stress, things just go. All right. Can you explain blocking? All right. So it's not as close to denial as it is close to something that is called repression that we'll talk about in a bit. Okay. So it works transiently to kind of eliminate stress that could be provoked by a thought or a feeling. Okay. But it's not, denial is like it didn't happen. All right. So it's very different. Now, regression is something that what it means is you go into like, you kind of almost go into a fetal position, you know, when you're so stressed or you're so sad. So block the thought of having an exam tomorrow. That's called denial. You're in denial of BHS. I'm just joking. So again, when you read the PDF, you will understand it again, because everything will be right in front of you. And so you can sort of go back and forth and compare. So regression is when you go into earlier phases of your development, okay? So like going into that fetal position because you're so upset or you're so sad or you're so disappointed. And so you tend to regress, okay? So it's an attempt to go to an earlier phase, all right, of functioning to reduce the tension, okay? You go to sleep in that fetal position, you're so stressed. And so that kind of protects your system somehow, okay? Again, it's not normal that you regress every time you have a stressful situation. It doesn't mean you go back to be a child. Do people regress ability-wise, forget skills? So no, these are defense mechanisms, okay? So this is not losing abilities. It's not like you're losing skills. So your system protects itself by regression. So it kind of takes you to an earlier phase of development when you were like younger and you didn't have that responsibility. So let's say somebody, every time they're stressed, they just go and they lock themselves up. They don't deal with the issue, right? They don't deal with it. They sleep. And then does that fix the problem? No, it does not. But, you know, that's how they know how to cope. They just cope by regression. I remember when I was doing my residency, I had an elderly patient. So she was like in her 50s or 60s, okay? And so, again, I was somebody who knew I wanted to do child psychiatry. So I felt like I couldn't really connect to her because of the age, like, you know, difference. And we were trying to implement some kind of psychotherapy that was really focused on identifying defense mechanisms and breaking them down. Okay, that was the objective. Is when you break these defense mechanisms down, you kind of liberate the person, and so they become more insightful, and then they can work around the problem versus, you know, their defense mechanism preventing them from doing so. Anyway, so with this patient, I wasn't getting anywhere. You know, I just found the sessions to be very boring and redundant, and she was bored as well. And, you know, a lot of times the sessions we can just, you know, we look at each other and there's not really much happening. And so I felt like I was a complete failure. And then these sessions were recorded. So I went to my supervisor. I'm like, you know, I'm not getting anywhere with this woman, you know, at all. So he, again, goes in, and we all learned that day because he was doing the session, and she obviously knew him because she had met him the first time around, and she knew that this was a training process and that I was the resident. So when he went in, he was pretty much really, like, I had already seen her for like almost 10 sessions. We're not getting anywhere. Part of the issue was me not feeling comfortable enough to kind of like, you know, confront her with these defense mechanisms, which were obviously happening as we were going along. Okay. So he goes in, and pretty much she's like sitting upright, you know, and then he goes in and he's like, you know, breaking them down. Just again, he was not being aggressive or mean, but he was just kind of putting all these dots on letters to bring it into awareness. And we could see her like physically regress. She was like shrinking into a ball. Okay. So she was regressing into like a fetus as he was doing this. Obviously, you know, the session didn't end this way, and he was able to put her back together, you know, and she was able to at the end to sit upright. But that was really interesting to see how you could physically see somebody regress and then, you know, kind of come out of it. I see it a lot with teenagers. So the teen comes in with parents, and the parents, all they're doing is, you know, teen comes in like macho, and then parents are like, you know, he's this negative, like everything negative in the world about him. And I could see this teen like shrink from like being completely upright into a ball, regressing right in front of my eyes because they're really breaking him down. So my job is, well, I say, well, is there anything that's positive? Can you tell me about his strengths? Okay. So I move it around and I say, can you tell me about his strengths? So he broke the defense or not? He didn't break it. Okay. He was highlighting them. He was bringing them into her conscious awareness as issues. So he was now making her uncomfortable. She was becoming uncomfortable. And that's why she was regressing, because he was telling her about, she knows that he was supervising these sessions. She knows that whatever we talk about was because it's part of the supervision. And so he brought into that time, events that have happened. And he was highlighting how these were not serving her at all. And so just bringing them into her conscious awareness, all of these things that she was trying to, not think about, block or repress, made her regress because she was becoming so aware, okay, at that time. So she regressed. Then he had to pull her back together, obviously, to get her, otherwise it's just not a pleasant experience. And then, and that's why she was regressing. So with teenagers, when we say, what are their strengths? So, tell them, the minute the parents talk about strength, you see the adolescent, starting to like sit upright again and kind of like blossom. Interestingly, this patient then continued with my supervisor. I didn't have, we were not a good fit, okay? She continued with the supervisor. He had videotaped sessions. And I want to tell you, I then started to see the most animated woman ever, okay? So she was super animated, super interactive. So that was a really good fit, she and him, okay? So that's another important point, is the goodness of fit to your therapist, between the therapist and the client. So you could be the best therapist on earth and they don't click. There's no rapport, there's no fit. And so the therapy doesn't work, not because the patient has problems that are beyond repair or that the therapist is lousy. It's just they don't match, they don't fit. So she, again, another lesson learned was that it was an amazing fit with my supervisor, and she really progressed and sorted out a lot of her issues and her symptoms, which were, again, a lot of passive aggressive behavior that she had, where I don't know if you've heard this term before. Have people heard passive aggressive? Again, it's one of these other late terms that we use when you tell someone, oh, you're so passive aggressive. Yeah, so passive aggressive, okay. So an example would be, instead of you telling someone about how you really feel, okay, you're passively aggressive about it. So example is, husband and wife, she doesn't want to go to see her in-laws. She's mad at him, okay? But instead of telling him, listen, I have a problem with you and with my in-laws, again, being confrontational, she starts to say, I really have headaches. And she probably may have headaches. Again, she's not being consciously passive aggressive, but I have headaches, I have backaches. And so she doesn't end up going. She doesn't end up confronting him with her issues, okay? And so this passive aggressive behavior, do you think it serves the person? Again, they're not confrontational. So they're pleasantly aggressive in the sense that they don't confront you, but at the same time, they're doing these things that are, not helping the relationship. Again, not a very conscious thing, but does it serve a function, or is it healthy? So it's protective, okay? But does it serve the function of relationships? No, it's not healthy, okay? So eventually what happens between this husband and wife is that, she's always complaining, she's always got like headaches and whatnot. So then there's going to be a gap, okay? They're going to drift away. Instead of you confronting your friend because they're hurtful to you, you start to, complain about things. And so you start to drift apart. Whereas, again, the problem with being passive aggressive is how it affects relationships. So people who are passive aggressive will come in and complain and say, I don't have friends. I can't keep friends. I'm not loved. People don't want me. Okay. But again, it's not because of them or you, it's because of this behavior. So the minute you start to kind of pinpoint, well, why don't you actually tell your husband that you're mad at him? Okay, why don't you say that you're upset with him? So usually there's a fear of what? Why is it that people don't confront others? What is the fear? What are they worried about? They're worried about rejection, abandonment, and loss. Okay. Now, do you think that these things could actually be a problem in the relationship, or these are all unconscious feelings and thoughts that this person may have that then kind of pushes them towards this behavior? Because this behavior protects them against these unconscious thoughts and feelings of abandonment, loss, and rejection, which may have, again, stemmed from earlier childhood where they may have actually been rejected or neglected by, a caregiver. Okay. So they kind of go on in the world not trusting relationships because relationships have not been consistent. Because if your primary relationship with your mom has not been a consistent one where there's no trust, and that, again, we talk about that relationship as being a prototype. So if your prototype relationship was negative, it leaves an imprint in your unconscious mind that, that all relationships will be like that. Okay. And so therefore you go into this pattern of being non-confrontational because you think that you're going to protect your relationships because then people will not leave you. But in fact, people do end up leaving because you're passive aggressive. Okay. It's not a healthy way of being. Okay. So I hope that makes sense to you and just understanding how things can stem and then kind of cause these types of behaviors. Introjection is new. Okay, so introjection is the internalization of qualities of an object. So qualities of someone that you introject. We're going to talk about this more in object relations, which is in a few slides. Okay. Introjection can be healthy because you can internalize, parts of people and they kind of, are with you. Okay. And it could be protective, like we said. You can introject parts of someone who passed away, and that becomes how you function. Because you've introjected. Okay. But you can also introject negative parts of people, and that's where it becomes an immature defense mechanism. So if you introject aggression, if you introject negative qualities, okay, you may then behave based on that introjection, and that becomes your pattern of relationships. Okay. And so this aggression, and you're not sure where that came from, but it's sort of an acquired behavior. Okay. And so you feel angry, you act out with anger. And so it's trying to understand where that came from, who in your life kind of treated you that way, and that's become your introjected prototype. Okay. Somatization is something that we see a lot in the medical field. So we see people with symptoms that are, stemming from something that's psychic, but presenting organically. So a very common example is people who have pseudo seizures. So they don't have actual seizures, but they faint. When you do an EEG, there's nothing. The EEG is normal. Or people who, will tell you that they have abnormal heartbeats. When you do an EKG, it's just, there's absolutely nothing. Okay. So it's how their inability to deal with their intrapsychic conflict is then somatized. And so they present with, it's a lot easier to say that, I can't walk, or I'm fainting, because it's externalized versus having to deal with the actual problem. So we refer these patients to be seen, to try to identify So is introjection projection? No, introjection is internalization. Projection is externalization. So they are different. Reverse projection. Yeah. So somatization, although like when we see people with pseudo seizures, we know what it is. So they don't have seizures. But can you tell the patient, hey, you don't have seizures, you're just pretending? Or it's your psyche is in conflict, and so that's why you're passing out? Can we say that? No. So why can't we say that? Because it's a fact. I mean, that's exactly what's happening. Why can't you tell someone like you don't have seizures, but you have psychic conflict, and that's why you're like falling? I mean, when we see these patients, yeah, you don't help the problem. But again, with kids, like who present with functional abdominal pain, so that's it. They present with abdominal pain, but there's absolutely no reason for them to have abdominal pain. Like they've had endoscopies and all sorts of investigations. There's absolutely nothing. So they won't accept it. Okay, it's a lot easier to accept that you have a medical problem than it is to accept that you have a psychological problem, because there is still a stigma that goes with psychological problem, because bottom line is I'm not crazy. Okay, so if you tell someone like you're fainting because you have a psychological problem, they're like, doctor, I'm not crazy. Okay, but what we say is that, because we have to tell them the truth, obviously, because otherwise, if I have seizures, if I'm fainting, why don't you put me on a medication to prevent my seizures? Well, you don't have seizures. But what we tell people is that sometimes everybody goes through stressful situations in life. Some of us know how to cope with it. Some of us need help coping with it. And sometimes when we are under this stress, our body kind of takes over and trying to help. And so our body reacts by fainting, falling, pain. It's kind of like a signal. Your body's shouting for help. That really sinks in well. They really take that well, because it's, again, you're not putting the blame on them. You're kind of neutralizing it, because it really is what it is, because their psychic conflict is unconscious to them. They don't know that there is something happening. Okay. And so their body responds. So you're actually telling, and that's where they need help. Maybe you need help in trying to understand why your body is responding the way that it does. Again, you're taking away the blame. You're not telling them that it's their fault. Okay. So again, you're the good enough mother who's not being judgmental. Okay. And you're giving them that space and helping them try to sort it out and understand. Now, neurotic defenses, again, these are like common. We see them a lot. Okay. So controlling, it's a defense mechanism, but it can be part of a behavior. Okay, you sometimes see people who really try to control their environment so much because they're so anxious. So neurosis is anxiety. Okay, so people that are extremely anxious manage their anxiety by controlling their environment. So it's a conscious thing that they're doing, but they don't know why they're doing it. Okay, so these people are not very flexible. It's really difficult to make them do things that are new. Okay, because it's going to provoke their anxiety. Okay, so this controlling, as well as reaction formation, we see it a lot in people who have obsessive compulsive either traits or disorder. Okay, so reaction formation is really the transformation of something that's unacceptable. So you have this impulse, okay, internally, and so you do the opposite of. So that's called reaction formation. So I feel my hands are dirty. Okay, that's it's a feeling that I cannot tolerate. So what am I going to do? I'm going to wash my hands. Okay, so that's, you do the opposite to kind of neutralize. Okay, you're doubting yourself, and so you start to check, because it's hard for me to kind of sit there with the thought that I'm not sure. So this anxiety of I'm not sure if I did or I didn't. So I'm going to repeat, I'm going to count. So reaction formation, we see a lot in people who have obsessive compulsive disorder or traits. Okay, so controlling and reaction formation, we see a lot with anxiety. Now, displacement, okay, is shifting an emotion, okay, from one idea or object to another. You displace, okay? So I'm really angry with, let's say, somebody who's really close to me. I'm really angry, okay? But that anger is going to be displaced because it's hard for me to confront them and tell them that I'm really mad. Again, this is not passive aggressive, but this anger is displaced onto, and then I go home and I shout at my kids. I could have dealt with my boss and sort of managed it there, but that anger is now displaced onto someone else. Okay. That negative emotion or affect is transformed from one place to another. So it's displaced. It's called displaced anger. Okay. Not a healthy way to be, because the healthy way to be is to manage it there and then. So passive aggressive, it's non-confrontational, but it doesn't come out onto someone else. It comes out onto me. Like, I have pain, I have aches, and so I don't go. It's not conscious. Okay. Let's see here. So I'm explaining the difference between that and passive aggressive. So passive aggressive, it's pretty much you with you. Okay. So I don't want to go, and so I don't want to deal with it, and so I feel pain and ache. Actually, they feel pain and ache. Okay. And so it can actually be like kind of a bit of somatization as well. Now, these defense mechanisms are very connected. So it's not like one person has only one. So you'll find like they're a group. So a lot of times people who have immature and neurotic defenses, they have like a mix and match, a garden variety. These two groups are commonly coexisting. The narcissistic group is usually seen in people who have, more intense, severe mental health issues. Okay. But the immature and neurotic, these are people who are, functioning people. Okay. They don't have disorders as such, but these defense mechanisms, if they are on the forefront, can be limiting. So it's like when you take it out on the same person, you do, is it the same when you take it out on the same person, but on a different thing? That's also like, that's also true. It's a good point. So, you're mad at the person, but you don't confront them, and you kind of let things go and slip, and then you lose it over something that doesn't really require that kind of a reaction. But usually displacement is usually on something else or someone else. So because not really on the same person, it's usually onto someone else or something else. Repression. Okay, so here is when things are really withheld from consciousness. So repression is used a lot with abuse. So victims of abuse, that's the defense mechanism that's used, because everything is repressed into the unconscious mind. Okay, so it's not denial, it's not blocked. Okay, it's repressed. It's actually not there. Okay, so these repressed memories or affect can be in your unconscious mind forever. Okay. Now, some would say, well, that's really protective, if things are always repressed. But you know what? People with repressed memories or repressed feelings are going to have interpersonal issues. Okay. But they're not going to understand why. So they may have intimacy issues. Okay. But they don't know why. And so when they go in to try to figure it out, like, why am I having these interpersonal issues with people that I thought I loved the most, then it can go back to, in therapy, sometimes these repressed memories do come out. Okay. And sometimes they don't. Okay. So repression is one of these really very difficult ones to kind of maneuver, because usually the repressed things are, extremely unhappy, unwanted. And so they really kind of kept away from the forefront. So externalization is this tendency to perceive in the external world, okay, something of your own personality. So you externalize. Now, how is that different from projection? Okay. So externalization is a more general term. So it's similar in concept to projection. Projection is very specific, and it's usually about very negative feelings that you may have about yourself. And again, we see projection mainly with personality disorders, okay? We don't see projection with more of the healthy kind of norm. So projection is very specific to personality disorder. Externalization, so people who tend to externalize, again, the baseline for this is anxiety. So generally we're talking about neurotic defenses, and the baseline here is people who tend to be more anxious people, okay? And so externalization of your anxiety so that, you know, you kind of, it comes out so that if it's kept in, your anxiety may tend to kind of be more manifest. Isolation here is splitting or separating an idea from an affect. I'm going to read it and explain that accompanies, but it is repressed, okay? Social isolation refers to the absence of object relationships. So sometimes, again, it serves to protect you from probably feelings of lack of trust, okay? So you tend to be kind of, not so consciously, but the way that you are interacting with people somehow tends to isolate you in a way or a form that should be protective, but it's actually not, because it's counterproductive and you are actually isolated, okay? So isolation as a defense mechanism seems protective because it's like, you know, engulfing you, but it's actually, you know, really keeping you away from having healthy relationships. Dissociation we see with some types of in anxiety disorders. So like for example, with post-traumatic stress. So you kind of, it's like an out-of-body experience, okay? So that what is happening to that is, this is not me. I'm not the one being abused. It's someone else. So it's protective in that way because, you know, the abuse or the harm or the trauma is not happening to me. I'm outside of my body looking at whoever that is that's being, you know, hurt. Now, this is not a delusion. So it's not like a delusion of, you know, you're like looking at someone who's not you. But people who've gone through trauma will tell you about dissociation. So I'm seeing this young girl, 12-year-old, who had been sexually molested at the age of 5 or 6, okay? So what she's experiencing now, like her mother is in a relationship, like to be married. And so anytime the stepdad gets close to her, she says, like, I feel like I'm not me. It's like I'm out of my body looking. Now, he didn't do anything, but she's so apprehensive and she's so worried. And we recently talked about, you know, the incidents that have happened to her, which were really traumatic, but she's trying to understand like this dissociation, like, why is it that every time this person is near me, I feel like this is not me, okay? So obviously, if this defense mechanism continues, there's going to be a gap in the relationship between her and her stepdad, who hasn't done anything and who doesn't understand why she's kind of like so detached, okay? So we're trying to work on that. She's 12, but I think she's like almost 30 in the way that she is, because again, another defense mechanism, which is intellectualization. So here, and when you work with anxious people who try to intellectualize everything, okay, and